So at this 630th ASH, we presented the final primary endpoint analysis of the MASTER trial. This was a study where we enrolled patients with newly diagnosed multiple myeloma who are amenable to autologous transplantation. And we treated everybody with 4 cycles of Dara-KRd, followed by an autologous transplant, and followed by MRD response-adapted consolidation that could be 0, 4, or 8 additional cycles of Dara-KRd. We measure MRD by next-generation sequencing, clonoSEQ, at each of those blocks of therapy. And for patients who had 2 consecutive MRD reads below 10 to minus 5, for example, post-induction and post-transplant, or post-transplant and post-4 cycles of consolidation, those patients cease therapy and enter a phase they call MRD sure, where they are observed without any treatment, but they are surveilled for the resurgence of MRD or clinical relapse. And what we found is in this population with 123 patients with enrichment for patients with high-risk cytogenetics, we found that the regimen was highly effective with 98% overall response rate, including 88% of complete responses. But more important, that 80% of the patients achieved MRD negatives to 10 to minus 5, and 66% MRD negative to 10 to minus 6. Importantly, 71% of the patients were able to reach 2 MRD negative reads and cease therapy and are being observed. With those outcomes, with that treatment, a 2-year progression-free survival remains above 95% for patients with standard risk myeloma or with high risk with 1 chromosome abnormality, but is lower for patients with 2 or more high-risk abnormality that we call ultra-high-risk myeloma. The same thing about overall survival. If you take those patients who cease therapy because they had 2 MRD negative and are being observed, after 1 year, the risk of resurgence of MRD is below 5% for standard and high risk, but is higher at 27% for patients with ultra-high-risk myeloma. What we learned from this study is, first, that we can do real-time response-adapted therapy trials in myeloma. It's applicable to 96% of the patients, and you are able to act on those MRD results. And there is this really clearly delineated path for treatment de-escalation, treatment cessation for the vast majority of the patients, including some high-risk patients. But for those minority that have ultra-high-risk myeloma, particularly if they fail to reach very deep response, there's still the ongoing necessity to further improve the therapy, which we intend to pursue going forward.